Well, good afternoon. It's really a pleasure to be here. It's been very stimulating all day to hear the discussions and to be in one of the small groups. At the Carter Center, we think globally, but we act locally. And with a little help, the communities we work in have been able to use their knowledge and cutting technologies to not only observe elections, but to move forward with treating various diseases that they decide are their priorities. And it gives them a greater chance of advancing economically as well as health-wise. We see the greatest challenge in the world today as being the disparity between the rich and the poor. And the results of this disparity are evident in all of the areas in which we work and are the root causes of some of the world's pressing problems such as starvation, illiteracy, environmental degradation, violent conflict, and unnecessary diseases. President Carter often remarks on the power of local communities to achieve great things, and in his 2002 Nobel Peace Prize lecture, he said, "I have witnessed the capacity of destitute people to persevere under heartbreaking conditions. I have come to admire their judgment and wisdom, their courage and faith, and their awesome accomplishments when given a chance to use their innate abilities." And that undergirds all of the work that the Carter Center does. We make sure we are listeners first before acting. If you look at the world and delineate the world's poorest countries that are deeply entrenched in political instability and poverty, that suffer from major health problems, you see that that's where the Carter Center is working. The people we serve live under extremely difficult conditions, isolated by poverty, disease, insecurity, and they're often forgotten. So we say we work with the forgotten people of the world, and many people fail to include them in the global community. Their voice may not always be heard, but it is powerful and certainly a testament to the capacity and dignity of the human spirit. Perhaps another way to look at the world, if we examine the world based on GDP, would give us a totally different picture and yet show the disparity between the rich areas of the world and the poor. And if we overlap that with the failed state index, you can see that the countries where the Carter Center are working also coincide with a number of those. But working in these countries presents an infrastructure challenge, and the partnerships that develop in being able to address these are remarkable. We talk about the Carter Center as waging peace, fighting disease, and building hope, and the building hope component is the far more important of the three. And although we are based in Atlanta with an affiliation with Emory University, our focus has been in other areas of the world. We are very driven by principles that include action, data-driven, based on specific outcomes and results. We try not to duplicate what other organizations are involved in, but try to enhance what they're doing. We address very difficult problems, knowing that even failure can be an acceptable risk that we would take. And we are nonpartisan in that we remain neutral in dispute resolution and don't line up with either side. And then the final thing is we believe people can make choices to improve their own lives when they are encouraged and given a little bit of knowledge and access to resources. And we do this through collaboration and partnerships in that we are very small and have to rely on many other organizations to carry out our work. On the peace side of the Carter Center, we have a number of programs. As more countries embrace democracy as their form of governance, the Carter Center has been a pioneer in the field of election observation that was mentioned in the introduction. And although we have monitored over 83 national elections to help ensure that people's wills will be honored, we're continuing to learn with each election. In fact, some of you have participated with us as election observers. After the elections, we worked to deepen democracy by nurturing the full participation of each citizen in policymaking and supporting the development of government institutions to bolster the rule of law, the fair administration of justice and access to information, and government transparency. But intrinsic to democracy and essential to peace is our underlying commitment to human rights. And so our human rights program is engaged in every aspect of our work. And we support the efforts of human rights activists at the grassroots level while also working to advance the national and international human rights laws. If no current avenues of mediation exist in a conflict, we work effectively with offering mediation, having access both at the grassroots and at the highest levels of the governments. The Carter Center Conflict Resolution Program has furthered avenues of peace in Africa, the Middle East, Latin America, and Asia. As I mentioned before, we do not let fear of failure hinder the work. Even if we do not achieve the objectives, we learn a tremendous amount. We advance peace in areas of infamous conflict. We work to protect the human rights amid devastating political oppressions and fear, and we strengthen democracy in many fragile states. And in working in partnership with the local communities, we feel that the people's voice is heard. Here's a few of the highlights of our past year's work. More than 5 million people were killed during the conflict in the Democratic Republic of Congo. And despite the presence of 20,000 UN troops on the ground, the conflict continues and civilians continue to be targeted. 71% of people in the Congo live under the threshold of poverty, and life expectancy in the Congo is 46 years. Malnutrition contributes to about half the total number of deaths among children under the age of 5, which is about 565,000 deaths a year. Congolese men and women have been able to cast a vote only once before, and that was in 2006, and the Carter Center was there. In a country the size of Western Europe and 1/4 the size of the US, there's less than 2,000 miles of paved road, whereas the US has 3 million miles of paved road. Sexual gender-based violence in the Democratic Republic of Congo is very common, and on an average, 1,100 cases of rape are reported on a monthly basis. 48% of all victims are under the age of 18. But from all of these great challenges, there are many stories of leaders and human rights advocates who have great hope for their country. They are operating in a relatively new civil society movement, one that would have been impossible 20 years ago under the Mobutu regime. At that time, human rights defenders could not speak out, and the potential for positive change and great social leadership was severely limited. We can all imagine how different our lives would be if we could not contribute to civic organizations, or if we couldn't volunteer for our communities or vote freely for our leaders. The Carter Center plays a major role in supporting local civil society actors and human rights defenders by providing them with the tools and knowledge to do what they do better and more efficiently. In 2006, we set up the Human Rights House in Kinshasa to provide space for local organizations to work, meet, and network. At the Human Rights House, local citizens provide legal assistance for victims of rape, raise awareness on human rights laws, provide literacy courses for adults, and protect children from sexual abuse and forced labor. Today, we support a network of 154 local non-governmental organizations, and through these organizations and their branches in the provinces, we have the potential to reach more than 1,000 organizations countrywide in Congo. These groups often do not have electricity on their premises, but they come to the Human Rights House, and we provide them with other resources and support as well. Some of these areas of support are internet access, training, coaching, helping them connect with other initiatives in Africa and around the world. And the Human Rights House has been delegated as a very safe space. With many threats and intimidation to human rights defenders, 11 human rights defenders have been killed in the Congo since 2006. They see the Human Rights House as a place to retreat. And we've set up a Human Rights Defenders Protection Program to help these individuals who are speaking out against abuse or injustice when they are threatened or arbitrarily arrested. Our staff regularly receive calls from the defenders who've been threatened or fear for their safety. And last month, our program hit a defender in a safe location when it was determined too unsafe for him to return home. We often have to weigh the advantage of supporting a defender versus, because sometimes the government can target these individuals if they speak out and are noticed versus allowing them to work undercover in their communities. We also work in Katanga, one of the main mining provinces of the Democratic Republic of Congo. In fact, you may have a piece of Katanga with you today. Coltan, which is a mineral used in mobile phones, comes from Katanga, and I think most of us have a mobile phone. One of our projects is assessing the human rights implications of the mining investments in the Democratic Republic of Congo. And we are preparing an internet-based interactive map that will enable anyone to see who is mining what and the impact it is having on communities throughout the Katanga province. One example of the environmental impact is shown in this photograph, where a team of Carter Center researchers are going out in the field to measure the levels of water pollution caused by the industrial mining sites. But there are other issues. Communities do not see the economic benefit of the investment, and miners receive minuscule pay, and many of them are children. The international presence is not lifting the standard of living, but depressing it. Finally, in the DRC, the Carter Center will be supporting the upcoming election process, as we've done in more than 83 elections, including most recently the historic election in Southern Sudan, in Guinea, and in Côte d'Ivoire. We will be deploying teams of international observers to observe the full scope of the election process. In fact, it was mentioned last night that in Sudan we only had one American there on the team, and the entire staff were either local or from many other countries. We will be able to observe the full scope of the election process, from the regulation as well as registration and the campaigning, the vote on election day, and any mediation of disputes that result. Our work also includes close dialogue with institutions of government. We aim to build bridges between civil society and government, and in the DRC we work closely with the Ministry of Justice and Human Rights and with the National Independent Electoral Commission. It is their election, and they need to set the standards. And we need to make sure that the voices of civil society institutions reach these higher levels in the government. It would be unrealistic to think that we could change everything in a country as big and complex as the DRC, but through our support to local civil society and by strengthening the foundations of democracy and human rights that are critical to building hope for a better future, we feel that the Congolese are making significant progress. As a pioneer in the field of election observation, the Carter Center has taken the lead on a large project with the UN and other major observation groups to build consensus among them on a common set of standards of how elections should be judged. Often we've seen various groups now go into countries, and many of the groups would say it's free and fair, whereas others have major concerns. And prior to this project, there was no single set of accepted standards for elections. Instead, election observers historically had referred to their own standards developed within their organization or at the regional level. This can lead to confusion when multiple organizations are observing different things and come to different conclusions. But the Carter Center has a unique capacity to do this work, and because we are not constrained by member states, as the UN or others might be, and we can take risk and ask controversial questions, and we'll state it as it is. We can work globally to push difficult discussions forward. We do not monitor elections in the United States, for instance, since the United States doesn't meet all the criteria for free and fair elections that are imposed on other countries, such as having a standard elections commission and a standardized ballot. In the US, as you know, each county can print its ballot as it wishes, and the results are often announced by the media long before the election ends. We have compiled, I know you can't read this, but you can maybe go to the website at some point, but we've developed international law which centers around the standards and how to build consensus. We've built on the work of other leaders in the field of international election observation, and we feel that with this, our goal is to identify the key principles, find commonalities among the sources that allow us to assert that the standards are, in fact, internationally accepted law. Through this process, we've expanded the traditional understanding of key electoral rights, such as the right to vote. We've added a much-needed element to our standards that allows the high-level human rights obligations to be used by observers in real-world election settings, so that when observers are asking questions or making observations, human rights are included. There is now an online database of close to 200 sources of international law that outline the key obligations, rights, and freedoms relevant to each part of the election process for any country. And this tool is available to anyone on the Carter Center's website, which is part of what you see there. In addition, the Carter Center began using these standards more systematically in our election observation missions, making sure that they were used by all observers, whether long-term or short-term, in all parts of the world. This ensures our teams are gathering the right information to assess whether fundamental electoral rights have been protected and fulfilled. It's also helped us conduct more in-depth analysis of election observation missions, and as a result, the Carter Center reports increasingly are being used as a resource and model by other organizations. The waging peace is what we've heard about. Fighting disease is the next step. And while our peace work often gets a lot of attention in the news because it touches closely on current political affairs, our health work is just as extensive, maybe even more so. And the largest portion of the Carter Center budget is dedicated to health. Half of the center's health programs address neglected tropical diseases, or NTDs. As with our peace work, our health work sets goals that many people think are too difficult to achieve. Eradicating disease, building healthcare infrastructure, helping communities take control of their own health despite extreme poverty and insecurity. But we believe in the vast potential of the communities we serve, and time and again, individuals in those communities have exceeded even our own aggressive goals and high expectations. We make sure that local people own the project and that they run the project, and it's theirs. Often we don't even put the Carter Center name on it. Based at the Carter Center is the International Task Force for Disease Eradication. And this is a group of scientists and notable international health organizations from around the world that meet several times a year at the center. The task force evaluates any of the control and prevention initiatives and the potential for eradicating or eliminating infectious diseases. The center is actively involved in addressing 2 diseases identified by the task force for eradication, one being dracunculiasis or guinea worm, and the other lymphatic filariasis. And 3 diseases identified for better control: onchocerciasis or river blindness, trachoma, and schistosomiasis. This is just a snapshot of the past year's work. This 5-year-old boy, Lotepi Lokusi, from southern Sudan, had a guinea worm emerge from his scalp last year. The 36-centimeter long worm took nearly 2 months to emerge. He stayed at the Carter Center-supported Guinea Worm Case Containment Center during this period of time, and for 9 days, he bravely endured a 1 to 2 hour session to remove the worm. Lotepi had his older brother with him during his stay at the containment center, who's pictured on the right with him. And these containment centers are free and provide food and lodging for the patients and a family member for the duration of the treatment. Today, Lotepi is guinea worm free, and health workers had trouble finding him recently when they went back into the area because he was busy herding his goats out in the countryside. But guinea worm, or dracunculiasis, is one of the oldest diseases known to man. It occurs in regions where ponds fill up during the rainy season, and that provides the drinking water during the dry season. Larvae are ingested when people drink from the still water. A year later, a worm, often 3 feet in length, secretes a chemical anywhere on the skin and emerges 1 to 2 centimeters a day. The worm is usually wound on a stick to prevent it from breaking and retreating into the tissue, which can result in necrosis or gangrene or frozen joints. And I've seen patients with 8 to 10 worms emerging at any one time, and the burning is intense. To relieve this terrible burning, victims often go into the stagnant ponds to cool off, and the worm immediately discharges eggs, thus renewing the cycle. Those afflicted with emerging guinea worms are incapacitated. They're unable to work in the fields. Children can't go to school, or they can't gather wood to build their fires to cook. Humans are the only host for guinea worm, and the cycle can be broken if you instruct the people not to drink water from the contaminated ponds, or not to go into the ponds if they have an emerging worm, so that the worm puts eggs in. And if they filter their water through a piece of cloth, it will take out the larvae. After getting the support of the President or Prime Minister and Minister of Health of a country, the Carter Center works with the local health workers, other organizations, village volunteers, to prevent the disease. The pictures on this slide are from our guinea worm ceremony held in February of this year to honor Nigeria and Niger for successfully halting guinea worm disease transmission. Nigeria at one time had the largest number of cases of guinea worm, and their last case was reported in November of 2008. Representatives from both countries, as well as from several previously and currently endemic countries, traveled to Atlanta to attend this ceremony, and we are now working hard in the remaining 3 countries with the disease: Sudan, Mali, and Ethiopia. This graph demonstrates how close we are to eradicating this disease. When we started, there were 3.5 million cases, and that was in 1986. The idea of eradicating a disease was a very distant goal, but The disease has been reduced by 99% through simple tools like education and changing behavior. And when guinea worm is gone, it will be one of the most important medical advances in history. A disease will have been wiped from the face of the earth without using a vaccine or medical treatment. As you know, the only other disease totally eradicated was smallpox, which was eradicated through the use of a vaccine. The credit for this achievement will largely belong to the communities themselves, who are among the world's poorest and most isolated. Many people think the references in the Old Testament to fiery serpent is really guinea worm because of the burning. And some people think that the physician insignia of a snake wrapped around a staff is really an early hieroglyphic of a sign with somebody who would help an individual with guinea worm by wrapping it on a stick to keep it from breaking off. I mentioned Ethiopia as one of the remaining guinea worm endemic countries. And what's unique about the Carter Center's work is that we layer the health programs so that in the same village, all of the volunteers are working on multiple illnesses and diseases. We therefore work in a number of different areas of Africa on multiple diseases through integrated programs. And one of the other health programs at the center is our trachoma control program. The Carter Center, in partnership with Lions Clubs International and the Conrad Hilton Foundation and the International Trachoma Initiative and Ministries of Health, we have been working to eliminate blinding trachoma in 6 African countries. It is a bacterial infection that is the leading cause of preventable blindness worldwide. As we know, the leading cause of blindness is cataract, but the most preventable cause of blindness is trachoma. Transmission takes place when the bacteria move from the eye of young children to the eyes of uninfected people through flies, through touching, through mother's shawls, through bed sheets, through pillows, through towels. And over time and after repeated infections, trachoma leads to permanent scarring of the inner eyelid, deforming the lid and causing the lashes to turn inward and press painfully against the eye. And all of us know how difficult and how painful it is to have one eyelash in our eye, but to think of all of your eyelashes scratching the cornea every day is almost unbelievable. The condition is called trichiasis. However, trachoma and its painful advanced stages can be prevented, and we use a safe strategy. The S is for simple surgery taught to local people who tie up the eyelid to keep the lashes from scratching the eyelid. The A is for antibiotics, and Pfizer has donated all of the zithromycin or Zithromax for this effort. The F is for facial cleanliness to prevent the disease, and mothers watching children's faces is vitally important. And E is for environmental changes to improve hygiene and sanitation. So building latrines is vitally important. And in Ethiopia, the villages themselves, just in the past few years, have built over 1.5 million latrines. President Carter came up to me and said, "You mean I've been governor of the state of Georgia and president of the United States, and I'm going to be known as the king of latrines?" And I said, well, that will probably have a far greater effect than many of your other actions as president in terms of people's lives. But young children like this little girl, Haimanot Shibabo, bear the heaviest burden of trachoma infections and are the main source of infections for other people. And Haimanot's mother and women like her are most likely to be blinded by trachoma because they are the primary caregivers of the young children. They keep infecting each other. Haimanot and her family live in the Amhara region of Ethiopia, the world's most endemic place for trachoma. And 5 years ago, I took this picture of Haimanot. That was in 2005, when she was demonstrating by play acting how she could use her latrine. She had her own child latrine next to her parents' latrine that she very happily wanted to show off. But I recently met her and her family again last October, and she's grown into a beautiful and responsible young 8-year-old, which is highly remarkable in that many children don't live beyond the age of 5. And during the past 5 years, her family had continued all of their work to fight trachoma and had been exposed or utilized every aspect of the SAFE strategy, even showing me their bed net that they were using to protect them against malaria and lymphatic filariasis. One of Hymenite's neighbors had received trichiasis surgery. Each family member had taken 3 rounds of azithromycin to prevent and treat the active infection. And health education on trachoma prevention took place in her school, and they've received a visit from a health extension worker. The family now is on its 3rd latrine, and with continued commitment from her family and others in the community, we will reach the goal of eliminating blinding trachoma in the Amhara region of Ethiopia by 2015. The photo on the left in the Americas shows an increasingly rare sight of a Guatemalan woman leading a man who is blind from river blindness. No new cases of blindness have occurred in the Americas since the 1990s. On the right, in Africa, is a Nigerian tailor named Zaki Bauchi, who almost lost his sight due to river blindness. But he received Carter Center-supported treatment, and he's returned to his trade, proud he once again can support his family. Onchocerciasis, or river blindness, is spread through the bites of small black flies that breed in rapidly flowing waters along fertile river banks. And it can cause intense itching, eyesight damage, and often blindness. The disease, again, has an enormous economic impact, preventing people from working, harvesting crops, receiving an education, or even taking care of their children. Unlike infections transmitted by biting insects, where one bite is enough to cause a serious disease such as malaria, hundreds of bites are usually required to acquire onchocerciasis. And the disease can be prevented through health education and the distribution of a medicine called ivermectin, or Mectizan, donated by Merck and Company. Mectizan kills the parasite's larvae in the body, preventing the blindness and the transmission of the disease. But people line up to get the medicine because of the itching, which is comparable to total body poison ivy 24 hours a day. And if any of you have had poison ivy, you know how uncomfortable that could be. And since the center's river blindness program began in 1996, more than 140 million doses of Mectizan have been administered in 11 countries. One aspect of our river blindness work is the effort to eliminate the disease from the Americas by 2015. The Center's Onchocerciasis Elimination Program for the Americas, referred to as OEPA, assists all 6 endemic Latin American countries, Brazil, Colombia, Ecuador, Guatemala, Mexico, and Venezuela, in their quest to stop river blindness transmission in the Western Hemisphere. We are very close to this goal, and this graph represents how many treatments have been distributed semi-annually paired with health education. You'll note that the graph is going down because it means more communities are able to halt treatment when transmission has been halted. The green represents the first treatment round, which is treatment within the first 6 months, and the blue the second round, which would be the second 6 months, and the twice per year treatment program. 7 of the original 13 endemic areas in Latin America have ended transmission, and Colombia and Ecuador have made history by becoming the first nations to halt river blindness transmission through mass drug administration. And we currently are testing strategies that may be applicable for river blindness elimination in Africa. Through Mrs. Carter's leadership, the Carter Center is one of the world's leading voices for improving mental health care worldwide. Our newest global project is in Liberia. In addition to already having one of the long partnerships with the nation through our peace programs, Liberia represents a clear challenge in global public health. It is a country that has fought through tremendous adversity and is now in the process of a national healing and recovery effort. Liberia suffered 13 years of civil war that included the use of rape and child soldiers as weapons. Approximately 40% of the 3.4 million population suffers from post-traumatic stress disorder. The nation has only one practicing psychiatrist. In response to this great need, the government recently made mental health a priority as the nation rebuilds and recovers. The Carter Center will be working with the Ministry of Health and Social Welfare over the next 5 years to help Liberia build a sustainable mental health care system and fight stigma against mental illnesses in the country. The picture on the left is our first group of health care professionals who are training to become certified mental health clinicians. They are visiting Grant Hospital, one of our partner clinical training sites, and in the only psychiatric hospital in the country with 36 beds. The picture on the right is a community drama about mental illnesses held on World Mental Health Day last year in Bong County. Our Liberian mental health program is taking lessons learned globally from our Ethiopian Public Health Training Initiative, which over the past 13 years, through efforts of the 7 universities in Ethiopia, have trained more than 26,000 rural healthcare professionals using health learning materials and training resources made by Ethiopians for Ethiopians. In fact, these 26,000 health professionals are women who will remain in the rural areas of Ethiopia. In only a few years, Liberia's integration of a new mental health care system into primary health care systems will serve as a model for developing countries as well, and also a model for wealthier nations such as the United States to follow. And on the left is a picture of a guinea worm eradication program health worker from southern Sudan. On the right is a woman voting in a village election in China, where we have continued to work for the last 13 years, although our work in China started in 1989. There are 2 points. One is that a broad-based approach to human rights, not only political rights, but social and economic rights, is necessary to creating and sustaining a peaceful world. The other is that with the right tools and knowledge, the people living in the poorest and most isolated parts of the world can act locally to improve their own lives, building hope on a global scale. As successes occur, communities become inspired to tackle other challenges with the same hard work and dedication. And it is really not too audacious to believe that working together, every man, woman, and child really can have the opportunity to enjoy good health and live in peace. I hope that each of you are inspired to dream the impossible and become partners in helping to shape the world in positive, long-lasting ways. Thank you very much.